My name is Shelby Allen. I've been a nurse for 8 years now. My specialty is cardiac.
So I'm Tessa. I got into nursing straight out of high school.
My name's Megan. I got into healthcare. My mom is a nurse and my parents have both worked in healthcare since I was small.
So we have a few clips for you on medical shows. So we're gonna get started with the first one here.
Long fall, axial load injury after his window washing platform gave out. GCS 3, BP 70 over palp, heart rate 135.
All right, that long fall, we're looking at injuries to the brain, spine, chest, and abdomen, let alone long bone fractures. Maggie, I need extra hands and an OR on alert.
Done.
What's he got for IV access?
16 gauge on both arms.
All right, very gently.
Yeah, I was very impressed that they were able to get 16 gauges, let alone in both arms. So the gauges work for IVs, that the smaller the number is, the bigger the needle is. Having a 16 gauge is normally used just in trauma emergency situations. At the bedside, I'll use 18, 20, or 22. For the most part, I was surprised because it seems like he is obviously bleeding, and I know they mentioned that he's bleeding into his cavity, his abdominal cavity, and so he is clearly going to be volume deficit. And so, you know, when you're losing a lot of blood, you lose the volume, which means your veins are smaller, so it's going to be a lot harder to get a 16 gauge in. So, I mean, color me impressed with that. But normally I have seen in situations where they'll use what's called an IO or an intraosseous type IV, so where they drill an IV catheter into, they usually will use the shin, but in his instance he does have quite a few injuries on, like you said, like all the long bones. It seems like that could be why they didn't get anything in, but let alone, I mean, I would have been happy with a 22 in that instance, which is a smaller one. So I was just very impressed that they got such big IVs in both arms when he had already lost a lot of volume. So
Everybody on my count. 1, 2, 3.
Good luck.
Thanks. All right, likely cavitary bleeding. Wheeler, get a groin line. Start the MTP, hang 2 units of O-neg on the rapid transfuser until we type and cross X-ray. I need chest, pelvis, and C-spine. And let's get the ultrasound over here to fast his belly.
Lungs are clear. All right. I'm gonna start the groin line.
Help me reduce this.
So several things there. Like you said, the lungs were clear. I'm very shocked that his lungs were clear, considering all of the, bone injuries that he had from this fall. I did like that they mentioned, we're gonna do O-negative blood for this patient until we type and cross him. So type and cross just means that we get the patient's blood type, essentially. O-negative is a very universal blood type, so everybody can have it, usually without any reactions. And then they mentioned on the rapid infuser, which just means that we're gonna be just pushing blood to try to keep his volume stabilized while he is continuously bleeding out.
Big fracture. Come on. 1, 2, 3.
X-ray.
All right, step back. Pelvis down, C-spine.
On the box.
Chest X-ray is up.
Tension hemopneumothorax, trachea shift.
First of all, the groin line, we normally make that a very sterile procedure because you're going into a big vein in there, and most likely they were going to make an arterial line. I don't know what their purpose was, so they didn't clarify whether it was going to be a venous access or an arterial access. That could be 2 different things, but regardless, that is a sterile procedure if we're going to do a line like that. But as you can see, they pulled up the X-ray and mentioned that he has a tension pneumothorax. So what that means is that he has a collapsed lung, and the pressure from that collapsed lung is causing so much force that it is moving the trachea, and that's what we call a tension pneumothorax. The doctor previously had said, oh, he has clear lungs, his lungs sound clear. Well, if you have a tension pneumothorax, that one side is there's gonna be no air movement on that one side. That does not correlate together whatsoever, so.
Venous return is down. Give me a chest tube. Show me the pelvis.
Got it.
Vertical shear of the left hemipelvis. It needs traction. Pull up the C-spine.
Up.
Multiple C-spine fractures. Wheeler, how's that groin line?
So then the other thing that he mentioned was he said it was a tension pneumothorax. So pneumo just means that it's air that's pushing there, but whenever he went and tried to put a chest tube in, you saw that huge gush of blood, And that's what we would call a hemothorax. So meaning that that cavity has been filled up with blood, creating all that pressure. And again, that can still cause the same effect of, pushing everything, but it's a hemothorax in that case. So we would try to get all that blood out, again, put the chest tube like he's trying to do, which is correct. Yeah, they are two different things. And the chest tube and the setting that we use for the chest tube would be different in that instance. So
Done.
All right, chest tubes in 2. Let's move. Justin didn't survive a 330-foot fall just to die in my trauma bay. Let's go, let's go.
Witnesses report that Mr. Pepper clung to his window washing platform as it fell, almost riding it like a surfboard. Physicists surmise this likely created wind resistance that not only slowed his plummet, but also absorbed some of the force from impact. That might explain how he survived such a horrific fall.
yeah, I think that makes a little bit more sense as far as, somebody just free falls from a 34th floor, I think is what they said, most likely wouldn't live. The physics of it make a little bit more sense of why maybe it wasn't as hard of an impact as it initially would have been had he not been on the window washing platform.
Dysentery bleeders are tied off. Let's resect the bowel quickly and move on. GIA 80 stapler with a reload.
50% of people who fall 4 to 5 stories die. 10 or 11, it's almost 100%, so this is a first.
There's an exception to every rule.
So they mentioned there's an exception to every rule, which I definitely don't disagree with, because what happens to one patient might kill one patient, but then the other patient might be completely different. Things affect everybody differently. What I can take may not be what the next person can take as well. Or if I have a full-blown stroke, I might have, full disabilities rather than the next patient. It just really does depend on what's going on with the patient, the environment, the care that you get as well. The doctor that you come into, the hospital that you go to, you think about rural communities, don't always have quick access to certain things. So, there are so many factors that play into a patient's outcomes. So.
33 stories, God. Massive subdural hemorrhage. Significant left shift. Big mass effect is crushing his brain inside of his skull.
Well, he did fall off a building.
Craniotomy, right?
To what end? He's coagulopathic. I go in and take out the clot, it'll just reaccumulate.
No, I don't think so. I'm actively giving him plasma platelets and cryo.
Which improve his overall chances of survival from 1% to 2%. I'm not opening up his skull. I question whether he's even strong enough for the CT, but that was your call.
If the pressure in his brain isn't relieved, it's over. That's 100%. I got him this far. He'll get through surgery.
All the king's horses and all the king's men. Guess they should have gone to you.
Normally when we hear about a shift in the brain that essentially creates the patient to be what we call brain dead, we look at their pupils in that instance. And so what I would have liked to know in that instance were his pupils what we call blown, so they have no reaction, and then you just see them, they take up like the entire, like the black part of it. That would have been a good thing to know, because once you have a pupil blown, that's the end, and that most likely I would imagine that is what's going on, because if he has such a shift. So I definitely side with the brain surgeon on that side, just because you have to look at risk versus benefit. I understand that it's going to be an emergency to try to undo the pressure on the brain like that, like you said, to what end, is it really going to be something that helps them if we're already this far? But also some doctors don't want to take liability if they have to look at cases as well, and is this something that is feasible that I can do, that I'm willing to put on my back? Because if that patient passes away during surgery, no less, that's kind of on him, and because he chose to do that. So that one's kind of a hard one. I feel like I would need more information in it. I'd love to get a doctor's reaction on that, because that was a doctor-doctor interaction, and I'm sure we just on the nursing side, I see specialties go back and forth with each other, just like you will never see cardiac agree with anybody from renal. They butt heads. So that'd be a very interesting take to hear from them.
He's in. Oh.
What's happening?
Where is that suction coming from? Don't even know.
Asystole, crash cart, and a chest tray.
Got it.
Okay.
Take over compressions.
Scalpels? You're operating here?
There's no electrical activity in the heart, so I can't shock it back.
Are you gonna open it so we can
Internal
do it?
CPR is my only option.
Oh my God. Yep. Oh, please. No one's ever, no.
He's not sterile.
At all.
And Rippy.
One out.
How do you, what are we doing in there?
Come on.
What is the thing?
All right.
This is.
We've got a rhythm.
Pause.
No,
that would never
that
happen.
was
That's
not.
never gonna happen.
And how did they have the tool to just crack the chest right there? Like, how is it like just
Somebody ran to the OR to get it, I guess.
30 seconds?
We're not doing that. He's not sterile.
We weren't even to the point of needing to do any of that. We could have given meds. We could have shocked him.
We could have
But
given
he
some
had to manually pump his own heart.
like this. There's not enough room.
Baby shark?
There's not enough room to do this. Typically when you see that, they're doing.
I mean, you're sticking your hand in a bowl of noodles and organs are like squishy.
What's happening?
Asystole, crash cart, and a chest tray.
Got it.
Take over compressions.
Scalpels? You're operating here?
There's no electrical activity in the heart, so I can't shock it back. Internal CPR is my only option.
Oh my God.
Got the retractor.
Peppy.
One out.
Come on. All right, we've got a rhythm. He's back. He's back.
Okay, well, I definitely have never seen that happen before. I think CPR probably would have been the way that this situation would have continued to go. I have seen, there's certain things, like a patient just had like a fresh open heart surgery. There's different ways you can do CPR. I know doctors have done that. I think that'd be more of a big surgery thing. But again, that's just me being inexperienced in that area. I don't know for sure. I definitely think that's very dangerous to do, and let alone with the family right there too. That's very traumatizing for the family. So most likely somebody would have removed them from the room to do that. Again, that would have needed to be a sterile procedure because you were opening them up essentially like surgery at the bedside. And so you think about how when we do surgery, we are making sure that everything's sterile, everything's clean, so that we reduce the risk of infection. And again, this patient now is probably going to end up with some other infection due to, him cutting him and opening his chest right at the bedside.
What would you say to someone who's interested in healthcare?
I would say make sure you have a passion for people. You have to have a certain level of caring for the people to want to treat them, to want to learn, and to want to do better.
What would you say to someone who's interested in healthcare?
So I was actually thinking about this on my way to work today, that I am the one out of my peers that loves my job. By getting this degree, by having my nursing degree, I get to wake up every day and be a part of somebody else's life and impact them in such a cool way.
And I think that there's so many different aspects of healthcare. So even if a 12-hour shift on the floor taking care of 7 or 8 patients isn't your jam, there's always something for somebody.
Look at us now, we're teaching.
We're teaching. There are nursing positions where you can work from home. You can work in a Fortune 500 company as an occupational health nurse, or you can get down and dirty in the ER.
But like working in healthcare, you really get to make a difference.
Thanks for watching. A big thank you to Shelby, Tessa, and Megan for joining us today and sharing their expertise. Nurses make a big difference in our lives, and nursing is in high demand right now. Being a nurse, you can make about $60,000 starting out, and it can definitely go up from there. And if you want to learn more about nursing, check out your local technical college. If you enjoyed this video, make sure to like and comment. YouTube Analytics says only 1% of you are subscribed right now, so make sure to hit that button, and we'll see you next time.